welcome back at the Medtronic webinar series. It's the second season and the second webinar of this season. And today we're going to talk about IBD surgery. And of course, we have a great faculty again. The usual suspects are Andreas Chemillet from Austria and Walter Brunner from Switzerland. And we have some great guest faculty with Stefan Brandt, also from Switzerland, same clinic as Walter, I believe, Friedrich Herbst from Austria, and from the Netherlands, Willem Bendelmans. Like I said, we're busy with the second season and the second webinar. Last year, we had a great webinar series of 12 modules with increasing complexity, starting with basic laparoscopic skills, increasing to transanal surgery. And if you're interested in those webinars, you can find them on YouTube. Just look on Medtronic and on a colorectal webinar series. So, like I said, second season and second webinar. We still have 3 webinars in the coming period. In September, we have 2 webinars. In October, 1 great final webinar on the ERAS protocol. So today, the subject is IBD surgery. And we're going to start off with Stefan Brandt and Walter Brunner, giving an overview on IBD, the gastroenterologist's perspective and the surgeon's perspective. Then Willem Bendelman is going to talk about surgery in Crohn's disease, and Friedrich is going to talk about surgery in ulcerative colitis.
Hello, everybody. From my side, we can start with the first lecture by Stefan Brandt, and I'll give back to Maite to open the screen.
The topic today I'm going to talk about is not necessarily a surgical topic. It's about medical therapy of IBD. And the main question is, what should a surgeon know about this medical therapy? Today, 1st of July, I think is a very good day to remember the contribution of an almost forgotten surgeon to the first description of Crohn's disease. This particular surgeon is Albert Berg, who died on July 1st, 1950, and he was the surgeon who performed the surgery of 13 out of his 14 patients Beryl Crohn described in his first report in 1932. So most likely, I think it's more contribution of a surgeon than gastroenterologist. Remarkably, he's even not on the author list. So I think it's certainly a good day to remember that. If you look in this particular paper from 1932, I think there's an important sentence mentioned. It's written, medical treatment is purely palliative and supportive. The proper approach to complete cure is by surgical resection of a disease segment. It was IBD therapy in 1932. And if you look today, I think we have a lot of means to treat IBD. Already in 1942, sulfasalazine has been invented. In the 1950s, we got the steroids. In the 1960s, azathioprine and 6-mercaptopurine. And certainly a major milestone was the invention of biologicals, the first of them, infliximab, introduced in the treatment of Crohn's disease in the late 1990s. If you look on our current treatment pyramid, it's pretty much the same way like these drugs were invented. Often we use first aminosalicylates, followed by steroids, immunomodulators, and often only in the end biologicals. I think that's certainly not what you should do in all of his patients. So how do we treat patients, IBD patients here in St. Gallen? And I would say it's important sometimes to hit hard and hit early. So your patients should not undergo the climb to the summit, suffering from fistula surgery and stenosis until you give them biologicals. There's a number of patients who would profit from an early use of biologicals. There's something I would describe as a hit list, patients which profit most from early use of biological, particularly young patients, patients with perianal disease, severe disease at disease onset, inflammatory stenosis, extensive disease with small bowel involvement, deep ulcerations, and patients who are steroid dependent. These would profit most from a biological. I want to give you in the following minutes a very quick overview about the 4 classes of drugs we use currently for IBD treatment. I want to start with the 5-aminosalicylates. I think even nowadays, a very good class of drugs to treat an acute flare and maintenance therapy in ulcerative colitis. So it's a very good drug for ulcerative colitis, but you have to remember it's not a good drug for Crohn's disease. There have been a number of meta-analyses, and one of the more current ones is shown here. And the efficacy to treat Crohn's disease with 5-ASA is pretty much the same like placebo treatment, if you can see here on the curve. So a good drug for ulcerative colitis, but not a good drug for Crohn's disease. The next class of drugs would be the steroids. And I think that's one of the most important sentences to remember from my talk. You should treat only acute flares, but certainly not doing maintenance therapy using steroids. If you do maintenance therapy, you can be quite sure that you will experience at least one of these side effects mentioned here, like high blood pressure, osteoporosis, and diabetes. And on top of this one, steroids are not able to prevent another Crohn's disease flare. So maintenance therapy with steroids should not be done under any circumstance. Steroids are certainly not a friend of surgeons. What you have to remember, there's an increased anastomotic leakage with high doses of steroids, particular dosages greater than 20 milligrams of prednisolone per day. But you cannot stop in some patients steroid treatment from one day to the other one. If these patients had for a long amount of time steroid treatment, you have to be aware of secondary hypercortisolism after stopping with steroids. So perioperatively, these patients would need hydrocortisone prophylaxis, something to remember for surgeons. The next class of medications I want to talk about are immunomodulators. The most often used drugs are azathioprine and dexmethylpurine, and these medications are not free of problems. Problem number one is that the maximum efficacy will be reached only after 12 weeks. So it takes a long amount of time until these drugs show their full efficacy, and that's not the drug of choice for induction therapy. That's even reflected in the current ECHO statement. The current ECHO guideline about Crohn's disease is mentioned. We suggest against the use of thiopurines as monotherapy for the induction of remission in Crohn's disease. So for induction not, there's room for maintenance therapy if you keep in mind the side effects of these drugs. That's problem number two. At least 20% of patients will suffer at least from one side effect using azathioprine or dexmethylpurine. The more common ones we observe are pancreatitis, elevated liver function tests, nausea, vomiting, cholestatic hepatitis, and bone marrow depression. It's, I think, commonly known, but what is not as commonly known is that azathioprine is already on the list of carcinogens already since the mid-1980s. And there's a particular problem for non-Hodgkin's lymphoma as well as squamous cell cancers of the skin. Our own group performed a study, compared the cancer incidence in a group with azathioprine treatment compared to monotherapy with anti-TNF agents. And as you can appreciate, indeed, there's an increased incidence of lymphoma as well as an increased incidence of skin cancers. So these patients have been screened regularly for skin cancers if you treat them with azathioprine. This moves me to the last class of drugs, the biologicals, particularly anti-TNF agents that can be used for acute flares and maintenance therapy of moderate to severe IBD. There's a long list of anti-TNF agents available. This list is not complete. Particular adalimumab biosimilars has a very long list in Europe right now. Even for gastroenterologists, it gets a bit more difficult to keep the overview about these drugs. The first drug of this class was infliximab, and for certain situations, such as fistulizing Crohn's disease, I would recommend still infliximab. The trial evidence is most convincing in this situation for infliximab. There was the first paper regarding that, a landmark paper by Dan Present from the Mount Sinai Hospital, the same hospital like Beryl Kronberg, and he showed convincingly that in half of the patients you even can achieve fistula healing using infliximab. And there was a response in almost 2/3 of the patients treated with infliximab. The question the surgeon usually has, do we have a risk of major complications using anti-TNF agents and other biologicals? And the literature is quite, I would say, inconsistent regarding that. Even meta-analysis come not to the same conclusion. There's an overview about 3 of the major meta-analysis, and their conclusion was major complications regarding surgery, no. But if you look more in the details, 2 out of these 3 meta-analysis showed an increased risk for infectious complications. Not all of the meta-analysis have shown that, but I would say there might be a slight increased risk for infectious complications. Our own group analyzed that, and what we did basically, we had a distance of 4 weeks between the last infliximab to surgery. And we could not show any increased risk for postoperative complication in patients with Crohn's disease undergoing abdominal surgery. So that's what I would recommend. Try in elective surgery, keeping a distance, the time distance of 4 weeks between the last anti-TNF agent and the surgery. It's also reflected in some recommendations. The major surgical department of the Mayo Clinic as well as the Cleveland Clinic recommend the same. In this excellent review regarding drug treatment during surgery, they recommend to discontinue 4 weeks prior to surgery, not to give an anti-TNF agent. It's not the last class of drugs what we have. There have been another number of medications introduced just recently. 2 of them, one is vedolizumab, the other one is ustekinumab, seem to be quite safe. If you look at the safety data, they seem to be even safer than the anti-TNF agents, which is not necessarily true for the third class of agents, the JAK inhibitors. Tofacitinib, I would not necessarily regard safer than anti-TNF agents. Why is vedolizumab so safe? First of all, it's very gut selective. So the main action of this drug is gut selective. The other way is the mode of action. Usually you find lymphocytes. They interact with integrin and alpha-4 beta-7 integrin with the SMADCAM1 receptor here on the endothelial cells. And these lymphocytes can transmigrate to the lamina propria. If you treat your patient then with vedolizumab, this will result in some kind of coding of his cells, vedolizumab coding, where alpha-4 beta-7 integrin cannot any longer interact with MADCAM1, and the lymphocytes will stay in the blood vessel, so are still able to be performing their immune functions which are necessary for functioning immune system. This makes vedolizumab a quite safe class of medication. The other drug is ustekinumab, also considered quite safe, belongs to the class of anti-interleukin-12, interleukin-23 agents. By inhibiting interleukin-23, this agent is inhibiting pro-inflammatory Th17 cells, and by inhibiting interleukin-12, this drug is inhibiting Th1 cells. And the inhibition of Th17 cells is quite effective in Crohn's disease, ulcerative colitis, and psoriasis. And often we have patients with 2 diseases such as Crohn's disease and psoriasis. I would say that's the drug of choice. In these patients, we can treat 2 different entities with the same type of drug. Finally, there's tofacitinib, as I pointed already out, from a safety aspect, not as safe as vedolizumab and ustekinumab. There has been shown an increased number of infections, particularly in terms of herpes zoster. There's a slight increase in TVT and pulmonary embolism. The drug is used only in ulcerative colitis, not in Crohn's disease. This is the first drug of a class of drugs which we will see most likely other members to arrive in clinical practice. They're called Janus kinase inhibitors. Janus kinases activate quite a large number of cytokines, and tofacitinib is inhibiting JAK2, JAK1, and JAK3. That means a large number of cytokines. The Janus kinase is derived from a Roman god of a beginning and the end, and I think that's a good signal to come to an end, not without mentioning Crohn again. He mentioned the proper approach to a complete cure is by surgical resection of a disease segment. And this is still true more than 90 or almost 90 years later after he wrote that. Where do we need surgery? Where do our drugs not work anymore? It's in particular non-inflammatory fibrous stenosis, what you find sometimes in Crohn's disease, but also in ulcerative colitis, severe refractory ulcerative colitis, very severe fistulas, which need often a protective ileostomy, carcinoma, high-grade dysplasia, as well as a toxic megacolon. Not all fibrostenosis have to undergo surgery. What we do here in St. Gallen, we try at least for fibrostenotic lesions, which are smaller than 5 centimeters, an approach of endoscopic dilatation. And I see the inflammatory stenosis as a good indication for medical therapy, particularly for anti-TNF antibodies. This is done in St. Gallen. It might be seen differently in Amsterdam, for instance. The surgeons always played a big role. And Willem Bemmelman will show you in his talk that even in early Crohn's disease, you may have good efficacy of laparoscopic surgery. The trial he is going to show, the LYRIC trial, showed basically that laparoscopic ileocecal resection had pretty much the same outcome like infliximab treatment. With that, I want to finish. The question was, what should a surgeon know? I would say these are the main important points the surgeon should know. Aminosalicylates only for flare and maintenance therapy of mild ulcerative colitis. The role in Crohn's disease, in my eyes, is not any longer existent. Steroids just for acute flares, not for maintenance therapy. Azathioprine and ceximacabtagene have a long time until they reach their full efficacy, so they're used for maintenance therapy, and the biologics usually work quite fast. You can use in acute flares and maintenance therapy of moderate and severe IBD. And even we are not in 1932 in Beryl Crohn, we have a number of indications where we need the surgeons, such as fibrostenosis, abscesses, carcinoma, and refractory ulcerative colitis. With that, I want to finish, and I'm more than happy to answer questions. Thank you.
Thank you very much, Stefan, for this great overview. We're going to keep the questions till the end. So I want to invite Walter to start his presentation and give the surgical standpoint or overview about IBD. Walter?
Okay, thanks a lot also from my side. And now the surgeon, and it's the surgeon who is working with Stefan Brandt. And I can say this is very important to work closely together. Nearly every week we have email, every week we have discussions about patients, and we go to them together. So it's very good to work together, the gastroenterologist, who is always the first probably to see IBD persons. So I would talk a little bit about how much are they, what do we expect, what is the role of surgery a little bit, when to operate and how to operate it, mainly how not to operate, will be covered by Willem Bemmelman and Friedrich Herbst, of course. I also talk very shortly about IBD medication, because this was covered by Stefan already, and there are some special situations I think surgeons should know. So the incidence, what we see is, and this is from 2011, that it's completely different about the countries, and some have a high and others have a low incidence. And there you see in this one, there is a lot of countries without the data. But what we see is that it's really about 50 to 200 people prevalence in Crohn's disease and 120 to 200 in ulcerative colitis. But this is going up in the last 50 years. And you see a picture from 2020 showing that it's going up the last 20 years and more than all countries where we know you see some are over 300 to 500 already. So this is very important for surgeons to know that this is a growing number of patients which will need medical treatment, but also maybe surgery. So the role of surgery in IBD, what is the aim of the treatment? And I clearly always state to the patient and also to our colleagues from the gastroenterologists, it's not the avoidance of surgery, and nor does surgery represent a failure of medical treatment. Surgery represents an integral feature of the multidisciplinary approach to an individual patient. And some need surgery and others need medication, and some need both, of course. So there is a patient's perspective, and we may not get around that at all, because that's mainly fear if they hear surgery, and that's fear of stoma. So we have to cover that in advance, of course. We have to think about their fear on reoperation, on morbidity, or for example, pouch failure, because then they are talking to others, so they are not sure if they really want to go for surgery. We have to cover that. On the other hand, the patients are often very well informed, sometimes better than the doctors treating them. They are somehow sophisticated and differentiated, so you cannot talk to them in 5 minutes about everything you need. So, and maybe some of them will be contacted lifelong. That also can happen. What is the surgeon's perspective? Of course, there are some you will have in an emergency setting with perforation, with a bleeding or toxic megacolon or fulminant colitis. There are others, of course, and that will be the main part, with an elective setting. And then the role of the surgeon is completely different in Crohn's disease, because there we are the troubleshooter. Surgery will never be curative, even they thought, but we will have a big part in some of the patients. Yeah, the opposite is in ulcerative colitis. So we can be curative for the disease, but it's a maximally invasive procedure. So the timing is the question when to do. You can look that up, and it's very good. And Stefan pointed it out, and I'm sure also Willem and Friedrich will come to that. There is, for Crohn's disease, but also for the ulcerative colitis, there is a lot of evidence which was collected together and presented, with giving a lot of answers to the main questions we are having. So for Crohn's disease, it's clear it's relapsing disease, and there is a lot of medical therapy, induction of remission, maintenance of remission. And you see, they wrote already it's avoidance of surgery, and maybe you can delay it, and some will be avoided, of course. But the more stricture we will come, the more penetrating, and maybe the medical therapy will not be enough, and then the surgery should come, and it should always be tailored on the Crohn's disease. It's never curative for Crohn at all. But sometimes for a special situation, it's necessary, mainly stenosing fistula. And also if you have young patients with a growth retardation, it's clear you have to do the operation. Of course, then it's tailored, and you only take the part which is necessary. In small bowel, you see the fat creeping pattern, so you know already the bowel looks completely different than a normal bowel looks. You see that here the fatty tissue is like growing around, and only small part is rested here of the small bowel. Nevertheless, 70% will have an operation sometimes in the first 10 to 15 years. Also, of course, with annular fistula. This is moving a little bit as Remicade also has an effect there, but around you have to be aware that many of the Crohn's patients will be operated. On the other hand, 1 year postoperative, 1 out of 5 to 1 out of 3 has a symptomatic recurrence, and 5 years postoperative, 20% had a reoperation. The aim, so of course, for all of these is reduction of recurrence and reoperation. We see that it depends on when it was diagnosed, and the earlier you operate on the patient, the higher is his recurrence rate. The surgery should be standard and has to solve any problems. You have a lot of many young patients, so pain and cosmetic plays a big role. The aim is minimal morbidity and zero mortality, of course, if we operate on Crohn's disease. And there are some risk factors, especially if current smoking, penetrating and structuring disease, if there is early steroid use, if it's ileal jejunal disease, and the young age at the diagnostic are risk factors to run into surgery in the Crohn's disease. What about the ulcerative colitis? Approximately 1/3 of all need a resecting surgery, and it could be total with end ileostomy or EPR, colectomy with end ileostomy or ileorectal. Friedrich will talk about that. And this is about 40 years ago that most of those procedures came true. So there are 2 strategies in the emergency. It's completely different, and Friedrich will show that, to do an end loop, but let the rectum if possible. And the elective goes to the pouch surgery if the function should be possible with the sphincter, of course. These are the 2, and sometimes it's ileorectal. And you see, and Friedrich, I guess, will cover that also. If we have an ileorectal anastomosis thing to think about, that's also for female fecundity, because we see that between 30 and 70% will have a problem with fecundity. And the laparoscopic EPR maybe is a little bit better, and so new numbers will come up soon. What about the cancer? Of course, this is also indication because ulcerative colitis has a higher risk of cancer. So if we can control it by colonoscopy, it's possible. If it cannot be controlled, so that's also if we have a non-polypoid ulcerative colitis with a dysplasia, we should consider the colectomy. And the same is the longer the disease is there and the extent and more severe or persistent inflammatory activities, the higher is the risk of colorectal cancer. Just to say that after 30 years, the cumulative risk is around 18%. So this is in the meta-analysis of 2001. So we will see what happens later on. And it depends on how long and how early it was in you see patients diagnosed, especially for high grade, the risk is more higher. What we should also consider is that they are at risk of developing colorectal cancer. So we have to discuss that. But there are some who have an even higher risk, and this is if they have a PSC additionally, or family history of colorectal cancer. So it got up to 5 to 8 times higher than patients with ulcerative colitis alone. So this should also be taken into account in a small group of patients. Younger patients than non-IBD, it will be with the cancer. And the overall survival is depending on the age, on comorbidities, and of course of cancer stage. What about postoperative, the pouchitis? This is also a thing you have to cover if you are a surgeon and you have to stay in close contact with gastroenterologists. So this is, could talk about 50 minutes about only that. So it's just important to cover that. Also in the ECHO guidelines, you will find some information about the pouch dysfunction and how you could treat it and the pouchitis. But it's very important that the surgeon is able to have a look on the pouch, because sometimes it's not a pouchitis, but it's fistula and problems with the pouch capacity, for example, or strictures. So we should consider that those patients also have extraintestinal manifestations, which do not belong to the surgical part and can be treated somewhere else. But we just should be aware if we go for operation that they have more problems probably, and especially that the coagulopathy is higher in IBD patients. I think this is important. So venous thromboembolism is higher. The prophylaxis should be extended, and that's also true for the portal vein thrombosis. Also, this is a severe complication of IBD, and it's more frequent in the postoperative setting. So be aware that maybe it should be prolonged thromboembolism prophylaxis. What about the perioperative things we can do? We can, of course, look on nutritional status. We should, in Crohn's disease, convince patients to stop smoking. What about the steroid therapy and the medication? Stefan covered that a little bit already. You should always have a proper diagnostic and a new one, if necessary, a recent one, and think of the prophylaxis, which should be sometimes extended to 28 days. So the perioperative medication we heard, less than 20 milligrams is okay. In prednisone, the anti-TNF have higher septic complications and lung complications. So we should have at least around 4 weeks, even if the safest period for remission is not really known, but 4 weeks is the recommendation. And also thiopurines and cyclopurines do not increase the risk of postoperative complications. So we should not have to change it. Some other X-course, what about IBD and hernia? The only thing is you should know, because they are operated several times, so they will be maybe coming back with an incisional hernia. The only important thing is don't put a mesh intra-abdominal in IBD patients, because otherwise they get maybe a fistula, and it's horrible to get that out, and they will lose another part of their small bowel again. So don't place a mesh intra-abdominal. So IBD and surgery, on the one hand, maybe we are only the troubleshooter. On the other hand, it could be a curative intention. We should be involved early in the treatment process and stay in close contact with interdisciplinary group. We have different options. It should be a tailored approach. And of course, it should be a specialized teams, because it's not easy to do the surgery. Often it's very, the breaking fatty tissue, and also the bowel, the vessels are very breakable. So it could be more bloody than you're used to it. And you have to avoid that if possible. Be aware also of repetitive surgery. So try to stay minimal invasive, bowel sparing, and if possible, don't do the mesh in abdominal if you do hernia surgery. Thanks a lot. And I'm also open for questions.
Well, thank you very much, Walter. We decided to have the questions, of course, at the end, but if everybody has questions, please place them in the Q&A section so we can collect them and we can ask them at the experts at the end. We will now progress to a presentation of Willem Bemmelmans, who's going to talk about specifically surgery in Crohn's disease. So Maite, if you can start that.
So good afternoon, ladies and gentlemen. I would like to elucidate a bit on surgery in Crohn's disease. So here are my disclosures. What I'm about to tell you most of it, you can read in the ECHO ECP consensus guidelines on surgery for Crohn's disease. I chaired this guideline group, and this paper was published in 2017, and I think shortly there will be an update. So what are the therapeutic targets? Well, these have been defined in the STRIDE initiative, and for Crohn's disease, the clinical and patient-reported outcomes concentrate around resolution of abdominal pain and diarrhea, and also about resolution of ulcerations at ileocolonoscopy. The STRIDE 1 targets have been updated with STRIDE 2, and now in addition, absence of disability and restoration of quality of life have been named as important targets. Surgery for IBD has evolved in 2021. We all know that we are targeting subspecialization of the surgeon. So in the old days, general surgeons would take care of IBD patients, then GI surgeons, then colorectal surgeons, and now we have even IBD surgeons. Decision-making has been done in multidisciplinary teams, and the surgeon is part of that team. Minimal invasive surgery is the preferred approach, and also patients should be treated in enhanced recovery programs. So what should be discussed in the MDTs? Well, first of all, the indication of surgery, the type of surgery, how we should optimize patients before surgery and after surgery, how the management of these patients should be with respect to prophylactic medication. And those are the patients that need surgery for complications. But there are also patients who are refractory to conventional biologicals or step-up conventional therapy, and they should be discussed whether surgery should be an alternative to a second-line biological. Well, let's first look at L1 and L3 disease. This is the Montreal classification. As you know, enteral Crohn's disease is localized mostly in the terminal ileum and the small bowel, and sometimes this is extended to parts of the colon, so that's ileocolic disease, L3 disease. For practical reasons, small bowel disease and ileocolic disease, you can subclassify this in different phenotypes based on the natural history of Crohn's disease. So first, Crohn's disease is in the inflammatory state of the disease. Then when complication arises, then you will have stricturizing or penetrating disease. Based on this natural history, we can subclassify ileocolic Crohn's disease in phenotypes uncomplicated disease, which consists of patients who come for the first time to the doctor, so they're medically naive patients. And we have also patients who do not respond anymore on conventional therapy, so they need a biological. Then we have complicated disease, consisting of predominantly fibrotic disease, patients with perforating ileitis with abscesses, and also with perforating ileitis with fistula. And this subclassification is important because it has profound consequences with respect to the management, medically, surgically, or interventionally, percutaneous drainage of abscesses, different preparations for surgery, so immediate surgery or delayed surgery, different type and staging of surgery, so one-stage surgery or multiple stages with stomas, and then restoration of continuity, and also the decision whether it could be done open or laparoscopically. So let's first look at complicated disease, predominantly fibrotic. There's no doubt that medical therapy has no role here, so either the segment should be resected, or if it's a very short segment, structuroplasties can be applied. If we look at perforating ileitis, then we have perforating ileitis with abscesses and fistulae. Well, this slide shows you the different types of symptomatic fistulae, so entrovesical fistulae, enterovaginal fistulae, and gastroduodenal-colonic fistulae, also quite often after prior ileocolic resection or as a result of unrecognized anastomotic leak. And there's no doubt that these patients require surgery because they're symptomatic. It's different when these patients have fistulizing phenotype, but have no symptoms. What should we do with these patients in this case? So if we have a fistulizing phenotype, it's a relatively short segment and they're refractory to medication, so we have no mucosal healing, then it's for debate whether these patients should require surgery. Well, there's a very interesting paper from Salnik showing a group of patients with fistulae who were asymptomatic, and he showed this in 3 time periods. And what he showed over these time periods is that patients were treated with more and more multiple drug combinations, that as a result of that, their weight loss before surgery increased over time, that the inflammatory mass that needed a resection consisted more and more innocent bystander bowel, so sigmoid, small bowel, etc., that needed to be resected because it was incorporated in the inflammatory mass, and that there was an increase over time in stoma rate and intra-abdominal abscesses. So in the presence of perforating disease, hydrocolic resection is strongly suggested, even if patients are asymptomatic, because on the long run, this might result in bigger operations with loss of more bowel that was not affected by the Crohn's disease. So perforating ileitis with abscesses should be drained first and managed with antibiotics. And then if the patient is recovered, a delayed resection is mostly necessary. So percutaneous drainage, antibiotics for at least 2 weeks. All immunosuppressive drugs can be stopped. Please leave the drain in situ until the surgery, otherwise you will have a recurrent abscess. Optimal nutritional therapy, preferably intravenously. And then if the inflammatory mass has reduced in size, it might be even possible to apply laparoscopic surgery without a stoma. So what about uncomplicated disease? Well, let's first look at the group of patients who fail conventional therapy. There we have the discussion, should we go for surgery or for anti-TNF medication? So we compared these 2 therapeutic options in the LYRIC study, showing that surgery was at least as good as anti-TNF therapy in this patient group with respect to the IBD-Q, but even better at the SF36 and the EQ5D. And of course, surgery was cost-effective if you compared it with the conventional anti-TNF. So more effective and less costly. If we look at the long-term results of the LYRIC study, then the patient group that was treated with anti-TNF, you see that after 5 years follow-up, almost half of these patients required surgery in the end. 40% was still on anti-TNF, and around 14% was switched to another biological. So they had either surgery or need to continue their biological. If you look at the resectional group, then you see that around 40% did not have any IBD therapy. 25% required an anti-TNF, and the rest, the remaining part, needed other medical therapy, but no recurrent resections within 5 years. So apparently we can provide the gastroenterologist a fresh start and change the natural history of the disease. So if we summarize the different phenotypes of ileocolic disease, then complicated disease is very well treated with surgery, and even the uncomplicated disease, when they fail on conventional medical therapy, surgery is a very good option. Only the patients who are medically naive, who are first diagnosed, there could be the discussion whether you would go for surgery first, but I think most groups will start medication in these patients. And the idea is that for first, even in this group surgery first, is that the bowel is already destroyed. And even if you can reduce the inflammatory component in that part of the bowel, then you remain with a scarred bowel. And so it could be better in the future to resect it and give the gastroenterologist a fresh start, that if the disease recurs, that they start treating the disease when it's still effective. So how should we do the operation? Well, in uncomplicated disease, mostly there's only a limited fragment, so this can be done single port or multi-port laparoscopic. In complicated disease, particularly the ileitis with abscesses and the fistulae, then sometimes, quite often, there is a big inflammatory mass. So, for instance, an hand assist approach, where you have a larger extraction site in the phalansteal position, is useful to extract the specimen. If there are fistulae, you have to resect the source organ and preserve the target organ. If the patient is in bad condition, then you could apply state surgery. So first resect the phlegm, make an ileostomy, and then join up the bowel parts if the patient has recovered. This is a picture of a single port ileocolic resection, and this is how it looks after surgery. We have to appreciate that ileocolic resection is a low-risk operation with few reoperations and a low morbidity, a quick recovery, a low rate of long-term problems with respect to cosmetics, body image, and incisional hernias, and it's a very durable operation. These are the surgical recurrences over time in our unit, and a unit combined with the Leuven series, and then in the Lyric. You see that over time the surgical recurrences reduce, and that's mainly because the gastroenterologists follow these patients better than before. So if they see inflammation 6 months after the surgery, they initiate medical therapy, preventing complications to occur. So an example of a big inflammatory mass that can be taken out with a hand port. So still a laparoscopic operation. Phalansteal incision is a very nice incision with a low rate of incisional hernia and wound infection. And in this way, and it has very good cosmetics. So in this way, you can deal with even a big inflammatory mass. 2 examples of enteral fistulae, an ilioduodenal fistula, where only the target organ needs to be taken care of, and so on the right you see an iliosigmoidal fistula where the terminal ileum is resected. So let's move to colonic disease, L2 disease. Well, the phenotype of the colonic disease dictates the type of surgical resection. So if you have limited segmental involvement, then you can do segmental resection. If you have a diffuse large bowel disease, then it depends whether there are whether there is perianal disease or whether the rectum is involved. So if there's no anoperianal disease and the small bowel is unaffected, then you can counsel the patient for restorative proctocolectomy with pouch. If there is a mild or moderate proctitis with a distensible rectum and an uninvolved perianal region, then the patient can be counseled for a colectomy with ileorectal anastomosis. Is there a severe proctitis with poorly distensible rectum, extensive perianal disease, then the total proctocolectomy with ileostomy is the preferred advice for the patient. If there are multiple segments, then we can take out the segments up to 2, otherwise you should do subtotal colectomy. And sometimes if patients are not ready for an end ileostomy, you can fashion a defunction ileostomy if there's severe proctocolitis. But this is only delay of surgery and will not solve the problem in the end. This is the basis for the segmental colectomy in Crohn's disease. according to the ECHA guidelines, if you have up to 2 involved segments, you can do 2 segmental resections. Otherwise, you should do a colectomy. Why should you do that? The advantage of segmental resections is that the function is probably better. The disadvantage is that the recurrence rate increases because you have more colon in situ. So what about the defunctional ileostomy for pancolitis? It's what I said, it's no long-term solution in most patients because most of them have perianal fistulae and proctitis, so you cannot close the stoma, you cannot do a subtotal colectomy and ileorectal anastomosis. There's a long-term cancer risk. Patients remain symptomatic, but you can use it as a first step to make the patient accustomed to a stoma. Bowel surgery for Crohn's disease can be done in select cases if the terminal ileum is unaffected and there are no perianal fistulae. We have to appreciate that the incidence of pouch-related complications will be higher than if the patient gets a pouch for ulcerative colitis, but still the long-term results are good if the pouch is made intentionally. So dysplasia and cancer is very important in the colonic involvement. We have to appreciate that colorectal cancer accounts for approximately 10 to 15% of all deaths in patients with ulcerative colitis and also having Crohn's disease. There's no reduction of colorectal cancer in IBD as opposed to the general trend, and so this is still on the rise. And we have to appreciate that inflammation-related dysplasia is probably mostly located in the whole colon. It's multifocal due to the field effect. It's quite often flat and difficult to detect, and there's a high miss rate of dysplasia. And so if there's high-grade dysplasia, which is not polypous, but flat, and it's associated with IBD, then mostly a colectomy is the way to go. We have to appreciate that isolated strictures in any setting should be considered malignant in IBD, and so you have to be very careful with isolated strictures. So, and it's quite difficult often to diagnose the true nature of these strictures. It's difficult to detect preoperatively. They have to be transversable and examinable to rule out cancer. You can only do segmental management of these strictures if you are sure that the rest of the colon has been fully assessed and is normal. If you're not able to survey, then you have to do a colectomy proximally. We see over time in the referral centers that the indication for colectomy in, for instance, ulcerative colitis, but also IBD, is changing from therapeutic refractory towards cancer. So a nice example is in the group of Ramsey that in the beginning for cancer, they operated 0.4%, and now they operate 9%. They do colectomies for cancer in IBD. In Leuven, we see the same trend, and also in Amsterdam, we see an increase in indication for colectomy in IBD for cancer and not for refractory disease. So finally, some slides about perianal disease. Perianal fistula constitute the majority of the fistula in Crohn's disease, and it has a cumulative incidence of 25%. So 1 out of 4 patients with Crohn's disease will develop perianal disease, and it's a quite disastrous condition which compromises the quality of life of these patients. Well, this is a schedule or algorithm how you should treat these patients. So it's very important to assess whether there's proctitis or no proctitis. If there's proctitis, there's no role for surgery other than placing setons to drain the fistula tracts. If there's no proctitis, then there's particularly for the simple fistula, there's a chance that these fistula can be treated surgically, mostly in combination with medication. An example of this is the fistula shown on the left slide. If the fistula is low, so it encompasses only a very small part of the external sphincter. You could do a fistulotomy, but not anteriorly, because then, particularly in women, the sphincter is very short there and you can create a keyhole defect. But mostly these patients should be treated with advancement plasties or the lift technique. We have shown in the PISA study in our unit that anti-TNF alone might provide clinical closure in half of these patients. But if you look at MR, then they're only in 14%, the fistula is really closed. If you combine anti-TNF with surgical closure, you will increase your clinical closure up to 70% and a true closure of 40%. This is the intention to treat. And if you do a per protocol analysis, you see that the anti-TNF only closes in 3% the fistula on MR. So anti-TNF only will not close the fistula. You should combine it with surgery for particularly the simple fistula. If the fistula is very complex, then of course surgery cannot play an important role other than big surgery in the sense of proctectomies. And so first, most of these patients will have a stoma, and then if that does not improve the complaints, then the rectum should be taken out. How should we take out the rectum? Well, we should do a TME type of proctectomy, so not a closed rectal dissection, because we believe that in the mesorectum there are pro-inflammatory cells which are fueling the inflammation. So you can take out the rectum, but if you preserve the mesorectum, then you will have a chronic abscess within the tube of the mesorectum. So you have to take it out, the mesorectum, and fill the defect with an omentoplasty. So to conclude, ladies and gentlemen, decision-making should be done in multidisciplinary teams. Early surgery for limited complicated disease. Consider also early surgery for uncomplicated disease. The phenotype of the Crohn's colitis dictates the type of resection. There's a high stoma rate if the rectum is involved or in case of perianal disease. Pouches do well in Crohn's disease, limited to the large bowel. And surveillance in the presence of inflammation is unreliable, so be careful that you will not miss an underlying dysplasia or cancer, and proctocolectomy in case of multifocality or flat dysplasia. I thank you for the attention.
Okay, thank you very much, Willem, for this great presentation. We now continue to the last speaker, who is also from Austria, Friedrich Herbst, and he's going to talk about surgery and ulcerative colitis. So Friedrich, if you want to share your presentation.
Thank you very much, Colin. And I'm really excited to be part of this great series of webinars. Sorry, just need to go back to this to the start slide. In ulcerative colitis as compared to Crohn's, we have a different situation that has been alluded to in the previous talks. And for the emergency procedures is actually currently always a colectomy with ileostomy. There has been some interest in just doing an ileostomy, which seems to be similarly effective if you take out the toxic dilatation part of acute operations, but there's limited data actually to this. In the elective procedures, obviously we have the non-restorative and the restorative options, and the non-restorative options in many countries actually usually the pouch procedure. It's limited to patients with oncological indications with cancers of the distal rectum, or if the sphincter is completely incompetent. So most patients will have a restorative option, and there are two options here for us. One is the pouch procedure, and the other is the ileorectal anastomosis. But that really depends on the state of the rectum, which very often is the most affected segment of the gut in colitis anyway. And then obviously we have the various access options, and the robotic has not many data at the moment, but it obviously contains in the group of laparoscopic surgery. And very often we have not a single operation, but a staged procedure for those cases. And as has been accepted now, is that if there is a competent center, that we should do laparoscopic operations for those patients in emergency as well, because it will reduce especially septic complications in that particular group of patients. There are some technical considerations in my mind that one should observe, and this is that it's a good idea to leave momentum in place, because quite often we may need that later on for filling up the pelvis, unless you have a case where you have to suspect a sealed perforation. Then usually it's wise not to leave the momentum, because you might open the perforation, then you will have propagation of infection in the abdominal cavity. It's a very good idea to remove a specimen through a stomacite, at least when you staple the rectum. There are people who will not do that, but exteriorize the rectum. Then you can take out the specimen via this route in the lower abdominal midline. And I think that the most important aspect in acute emergency surgery is to avoid bowel perforation at any cost. And this is not only during dissection, but also during removal of a specimen. If you have a very small site for removal, a lot of fluid will accumulate in the last bit of last segment of bowel you take out, and this can lead to bursting. And so it's important to put this bit into a watertight bag in order to prevent this complication from happening. Now, in the elective surgery, obviously, everybody wants to do laparoscopic surgery, even if it's quite complex, especially in pouch surgery. And the main advantage is, as we've discussed already, is the reduction of adhesion formation, and also reduced negative effect on fecundity in especially young women. And Willem and his group have done a randomized trial a long time ago that especially women perceive scars after laparoscopic surgery a lot more positively than men, where it's less important. If you look at fecundity in general, I think it's worth noting that it's not only surgery that potentially reduces fertility by way of creating adhesions, but it's also the disease activity. So it's extremely important to medically cut down on disease activity for women who want to get pregnant anyway. Now, when we talk about what type of minimally invasive surgery we should employ in UC surgery, then we have to accept that there's only limited data on proctocolectomy. Most of the surgeries will be done nowadays as multi-port operations. There have been small series showing that single incision and reduced port accesses are feasible, but there are no comparative studies versus multi-port surgery. And then there has been an application of transanal TME type or perimuscular type dissection in pouch surgery, which has created a lot of interest in recent years. Now, in contrast to Crohn's disease, obviously we have a different discussion in colitis when we talk about how to deal with the mesentery. And it's clear that if there's cancer or dysplasia anywhere in the bowel, that it's recommended to employ an oncologic type of mesenteric resection for all of the large bowel and rectum, because of the high risk of unrecognized dysplasia and or cancer in inflamed bowel. But for people who don't have had a dysplasia cancer diagnosed, we can employ a tubular resection. The question then is, why is that attractive? Obviously, it creates a lesser wound area with an ensuing reduced risk for postoperative small bowel obstruction. It also will reduce the risk of ureteric or autonomic nerve injury, especially during the rectal dissection. And if you do a non-restorative procedure, it will reduce the risk of perineal wound healing disturbances. What I do if I do a non-oncologic type of resection, I will start dividing the transverse mesocolon first. You see this is entering the lesser sac and opening, just following the mesentery. And it's what I would call a convenience dissection. Depending on the friability of the meso, it's a good idea to just do your division where it appears to be safest. And obviously, as you approach the splenic flexure area, this will be a more tubular resection than in the transverse colon anyway. Now, when we switch to the type of procedure we may do, then obviously there's a long list of pros and cons to distinguish between IRA and the pouch procedure. And the main thing is that patients after an IRA will need maintenance therapy, will be at risk of recurrent or persistent disease, and also will have a rectum in place where you can get cancer in the long run. So the statement there is that under optimal circumstances, it's a good alternative to the pouch procedure. And this also obviously encompasses the fact that IRA is a single-stage procedure as compared to pouch surgery, which is at least a two-stage procedure in those patients. The other thing is that patients need to be aware that they have to follow a close surveillance protocol, and about half of them will lose their rectum anyway later in time. But that can be a procedure that defers definitive surgery, so to say, to a later stage. Now, interestingly, the recommendations are one thing, and clinical practice is another thing. And this is just out of curiosity, I thought I'd include that. This is a comparison of England and Sweden, where there are health registries where each hospital episode in patients is noted. And you can see it's almost 100,000 patients over the 11-year period that's been looked at. And there are striking differences actually between England and Sweden concerning the colectomy incidence, so the risk of patients to undergo colectomy, which is much higher in England than in Sweden. And on the other hand, the restorative surgery option is used much less in Britain. And on the other hand, if you look at England, almost all patients undergo pouch surgery if they even have restorative surgery. And on the other hand, about 60% of people in Sweden will have an IRA performed. So the authors have stated that that's not, the discrepancies are not fully understood, but that's obviously there are practice differences, which actually also will involve will change your decision, perhaps, even if the medical side of things can be clear. Now let's switch to the rectal dissection. And in the previous lecture, you've heard that in Crohn's, the proctectomy always should be done similar to the cancer dissection because of the risk of chronic abscess and fistula formation. The contrary is true for rectal dissection, unless you have a case of cancer and or dysplasia, obviously. So in this surgery, it's it's beneficial to leave the meso in place for those patients. It's certainly true that doing a close rectal dissection enables you to tell the patient that you've done the maximum that's possible to prevent autonomic nerve damage. Although, if you look at, for example, this Oxford series, the difference may not be so great. As you see here on the lower part of the slide, they didn't produce any men with impotence when they were younger than 50. And the other thing is that it's, as I've said, it's beneficial for complications, and also it only increases the operative time moderately. Now, this is a short video sequence to show what I was talking about. Obviously, by leaving the omentum in place, there's no risk at all to damage any retroperitoneal structures. That will be less obvious the lower you get down into the pelvis, obviously, and we will have to get closer to the rectal tube in the extraperitoneal part, and that carries a risk of injuring or opening the bowel, which should be avoided if at all possible. Now, in the anterior dissection, obviously, we will not go ahead like we would do in an oncology type resection, but stay very close to the rectal tube there. This is obviously a case where visibility is very good. In men with a very long pelvis, it can be difficult to ascertain where the bowel ends. And the other thing is, with inflamed rectums, this is a hazardous area here in the anterior part. It's very important to be certain where to stop, and putting a finger up for the back passage, as you can see here, is very important to my mind, to not to leave too much length of rectum in the patient. Now, to just finish up the technical side of that is, as I've said before, we should preserve the omentum unless it's oncologically required, or because of the risk of opening a seal perforation, and that likewise applies to leaving the phrenicocholic ligament, which will reduce the risk of splenic injury. Now, when we retrieve the specimen in non-restorative and or restorative procedures and construct the pouch, the question is, where should we do that? And Willem has already pointed out that Phanersteel incision is a very beneficial one, especially also because of the low risk of incisional hernia and wound infection. But depending on the type of patient we're operating on, there are men with fairly fatty or short mesenteries where trying to construct a pouch through a stomach site when it's planned, or phalansteal incision can be difficult and not reliable. So that will mean that in some patients we still will need to employ midline small laparotomy to do that safely. Obviously, in women, we can use the transvaginal route to take out a specimen, unless if there's no pouch planned and also no stoma planned. And transanal route is, if you want to apply that, it's mainly for non-restorative operations, or if there's a very lean type specimen and you do a transanal dissection anyway. Now, when we look at the construction, you all are aware that out of the many different types of pouch we can do, the J and S are the ones that are employed most of the time, especially the J, because it's easy to construct, it's very quick to do. You will use about 30 centimeters of the ileum for constructing that, and it relies it empties reliably. It's obvious that for patients where the J will not reach, we will need to do something about that. And the pouch type where you gain maximum length obviously is the S pouch, which but then means that it needs to be constructed manually. There's no way of stapling that. The ilioanal anastomosis should be stapled because it will lead to better functional outcomes. And the only reasons where we should consider mucosectomy and a hand-sewn anastomosis is if there has been demonstrated dysplasia in the lower 2/3 of the rectum, or if it's severely inflamed, including the transitional zone, where stapling can be hazardous, or in patients with sclerosing cholangitis. In many of these patients, there will be some problem to get down the pouch to the pelvic floor, and it's important to do what's called a trial descent, which just means that after you've taken out your colon and rectum, bring down the point of the planned point of anastomosis before you create the pouch, and see if it will reach. And depending on that, then do steps to gain more length. First step always is to maximize mobilization of the mesenteric root. The second is using those what's called stepladder incisions at the front and the back of the mesentery, which will give you something up to about 5-6 centimeters. And for patients who need an S, obviously division of the ileocolic is mandatory to actually gain that additional bit of length. There's another element in technicality, and this is about staging of the operation in elective surgery. Obviously, there's an option to do this three-stage procedure or a two-stage procedure if you leave out the ileostomy. But this carries quite a high risk of septic complications of the anastomosis. So there has been discussion how to better that. And in patients who will get a stoma, obviously the reported risks for bowel obstruction are up to 30%. That's mainly from the time when most of these operations have been done in an open fashion. But anyway, even in the laparoscopic era, there have been alternatives explored. And now there's something which is called a modified two-stage operation, where in the first operation, just a colectomy is done. And when patients have been weaned off every possible medication, then a pouch extraction is done without an ileostomy. So you end up with a two-stage procedure anyway. And if you look at the recent laparoscopic series, you can see this is a compilation of 4 European expert centers, including Willem Bemelman's group, in more than 500 patients. You can see that the global small bowel obstruction rate was 8%, but it's been most increased in the traditional two-stage operation, where the proctocolectomy with pouch construction and ileostomy is the first stage, and the second is the ileostomy closure. It's less in the 3-stage, and this just means that the difference obviously is in the combination of creating those huge wound surfaces in one operation. And when they've looked at the risk factors for small bowel obstruction, it's obviously if you get a septic complication in the abdomen, if there's early or late stoma-related complications, or if patients develop a hernia. On the other hand, if you do a colectomy as the first operation without reconstructing anything, that obviously prevents about 60% of instances of small bowel obstruction. Just recently, André Dohr published their most recent series, and out of those 109 patients, almost 70% had a transanal IPA with closed rectal dissection and without a stoma. And it's interesting to see that this, in their hands, that's a very safe and low mobility surgery. They had a fairly high leak rate of 11%. All those were treated with ileostomies, and they were able to close all these ileostomies. And so that's an encouraging new approach, but we will see whether it will fetch on to general practice here. And obviously, as in all low pelvic dissections, it's the men who are at highest risk, and in this series also, age was a predictor. So, as you've seen, this is a fairly complex subject, especially also from a technical viewpoint. And I thought I'd finish with my personal approach, how I do that. I still do multiport surgery in the pouch operations. I will do transanal dissection for completion proctectomy and non-restorative cases. I will use any utility incision that's available depending on patient type and situation and type of operation. I will not resect the mesentery unless it's oncologically required, and preserve the omentum and also phrenic ligament if possible. My sequence of operation is start on the left side, then to the right, and leave the rectum for last. And I'm fairly conservative. I will still use a diverting stoma in pouches. Thank you very much for your attention.
Well, thank you for this excellent presentation. All the others, thank you. So we have a couple of minutes for discussion, and I have seen no question at all in the chat room. Colin, did you get any questions?
No, I didn't see any questions, but I have a question for Stefan and Walter. Do you think that the technique as Willem Bemelmans presents with more aggressive and earlier surgery, do you practice that in your clinic, or do you think it's actually too aggressive? Do you think it should be more medically treated?
I think the Lyric trial gave quite some evidence for a little bit more aggressive surgical move in early disease. But in the clinical reality, I would say in the end, it's the patient. You know, if you discuss options with a patient, it's usually like the final door he wants to open surgery. So a far majority of patients would opt for medical treatment. I certainly would separate cases. You know, if you find maybe a long-lasting disease, patient discovered late in the course of disease with a long segment of fibrostenosis, which can be sometimes present already early in the course, even in the gastroenterology department. And I think I would opt earlier to surgery, because lifelong the risk in these patients is very, very high that they end up anyhow with ileocecal resection. On the other hand, I mean, and even the Lyric trial showed that many of these patients will have recurrent disease, anastomosis. So many patients who do surgery, they still will have in the end anti-TNF treatment. So it's not like that you completely spare the patient from aggressive biological therapy in all cases. Walter, I'm not sure if you want to add something.
Maybe I would add that it's very important to stay in close contact, and what we do, we go to the patient together, because I think the surgeons should talk about surgery, the physician, the gastroenterologist is talking about the medication, and it really makes sense to make them close really together. That's the best way, and it's true, they will have surgery maybe later on, they will have recurrence later on. So it's not either or, neither or, but it really depends on the setting, and that's new data which is interesting. We have to discuss, but the decision is done with the patient together.
I have another question. In the video, maybe this is one for Walter. In the video of Willem, you see that he staples a fistula tract between the small bowel and the sigmoid. And just to be sure, do you think that's a sufficient treatment of the fistula, or do you think that both sides of the fistula tract should be excised?
So what we know is that the active part of the Crohn has to be resected and not the inactive part. So it could be enough that the inactive part is just either, if he staples it away, it should be complete. If it just staples the fistula, it could be dangerous. But nevertheless, if the major point is the small bowel, and then there is a longer tract, so you can staple it and it should be enough and not have to excise it on the bowel itself if there is no Crohn. If Crohn is on both sides, that's a different thing.
Thank you very much.
I think we received one question in the chat. It says, in emergency subtotal colectomy, if the rectum is stapled, then what is the risk of pelvic sepsis? Meaning mostly, I think, of leakage.
That's obviously a question for me. There's been a number of papers that have looked at that, and the rectal stump insufficiency rate has been published as high as 25%. And the question then is, what are the options to reduce that? Now there is one is to leave distal sigmoid in the patient if that's technically possible, and bring it out either as a mucous fistula or place it subcutaneously. So if a leak arises, it will just create a wound infection there with a little bit of mucus leak. If you elect to staple the rectum, you will need to make sure that you don't break it. It's not always easy to be sure about that. People have oversewn the suture line, and if you're not terribly happy with how it looks, that's a very good idea. Also, a very good idea is to put a transanal catheter in to reduce the risk blowout, so to say, and especially evacuate the rectum. But anyway, there hasn't been a general recommendation to use either or other method of finishing the operation after emergency colectomy.
Okay, thank you. And I personally have a final question, maybe to you, Fritz, or to Walter. Just from the daily practice, you get from the internal ward a young patient, female patient with a acute Crohn's disease with abscess formation in the final terminal ileum. You think you have to do an ileocecal resection. You can't do a drainage. and she has a corticosteroid therapy. Do you think to do an anastomosis or no in the emergency situation?
Well, I think it's an easy question, but it's there are many situations that are comprised in that. One is that there are different sites of abscesses, and even if it's very rare that you can't drain an abscess. Conventionally, our radiologists may not be able to drain that, but you can do especially in young women with pelvic abscesses, you can do a transvaginal drainage and a bailout. I think it's really very rare to have to do an acute as an emergency operation and resect that. And we know that you will have a leak rate of about 15% if you join up. But it's a matter of intraoperative judgment if you do that or not. I mean, I think one should be quite liberal with giving those patients a stoma, especially if they're very ill.
I would totally agree, and especially the situations are often like that they are in a subileus and there is a chronic dilatation. So I would go for a split stoma. That would be the option, and we had some of those cases where you cannot avoid the emergency operation. So then I think split stoma is better choice.
So I think it was an excellent session, and we are almost in time, a few minutes behind. And
Andreas, I see there is another question on Crohn OS, because this is raising in the literature now or in the Congress, that we should perform a Crohn OS anastomosis in Crohn's disease. Actually, we discussed that hot, and I guess to reduce the recurrence rate will not be the job of the kind of anastomosis. I'm not sure if this works, if we surgeons do other things. If you have stenosis, okay, that's a problem, absolutely. But I'm not sure if we can avoid recurrence in having a Crohn OS anastomosis. The data is not that bad, so we do not do it, but there are, especially I think German hospitals are changing now a little bit to Crohn OS, so we will have a look what happens in the next years. Friedrich, what do you think?
Well, I have a little bit of difficulty understanding why that should reduce the risk for recurrence, because I mean the philosophy is that the Crohn OS only uses antimesenteric part of colon, ileum and colon for that, but that's the same in the way we're doing what's called the large. The traditional stapled anastomosis. Now also, if you're doing intracorporeal anastomosis in laparoscopic surgery, you will have a side-to-side, which purely encompasses antimesenteric bowel, and then you will stitch up the incision opening. And the recurrences will not be at the staple line, but at the end, or the part of the ileum that's actually leading to the anastomosis. So I don't know how that works. It still may be sort of time bias. Obviously, we've seen that with aggressive medical therapy, the reoperations and symptomatic recurrences have gone down dramatically. So I wait for a big randomized trial to convince me.
And maybe to add one thing, because you brought up a good point, Andreas, with the emergency ward, people with abdominal pain on the right side. So if you go in for laparoscopy thinking it's an appendicitis, and you see that it looks like a Crohn, so don't do the appendectomy. So that's an important thing. Don't do the appendectomy, but just make the diagnosis, go out again, send it to the gastroenterologist to make a proper workup and then medication probably, but don't do only appendectomy if it's not the appendicitis.
And also don't do ileocolic resection. Because you think it's Crohn.
Yeah.
Okay. I think this had just really excellent presentations and good remarks to close the discussion. I just want to remind that there will be a The next webinar will be in September 2nd, dealing with endometriosis and rectovaginal fistula. So all the audience, please keep in mind there will be a summer break and the next webinar will be in September. I see no more questions in the chat now and in the F&A section. Are there any other remarks from the panelists, from the presenters? If not, I would really like to thank you for an excellent meeting, for an excellent webinar. Thank all of you, and bye-bye.
Thank you, everybody. Thanks.
Bye-bye. Have a nice evening.